Hello, everyone. Thank you for being here this afternoon. Today, we're pleased to welcome Professor Mavura and Dr. Doriane Sabushimike, two very special guests from Moshi, Tanzania. Professor Mavura is the current principal of the Regional Dermatology Training Center in Moshi, Tanzania, as well as the president of the Tanzanian Society of Dermatology. The Regional Dermatology Training Center is a tertiary training institute of both the Tumani University and the Muhimbili University of Health Sciences. Professor Mavura is also a senior lecturer of both institutions. He has specialized in dermatosurgery and has published and co-authored several papers on tropical dermatology. We are also pleased to introduce Dr. Doriane Sabushimike. She's a resident in dermatovenerology at the Regional Dermatology Training Center, and she's also one of the members of the GlowDerm Training Committee. Today, they will share with us their expert opinion on albinism. When you're ready, Professor Mavura and Dr. Sabushimike, you can share your screen.
Hello, can you hear me?
Yeah, we can hear you perfectly.
Okay, thank you, Dr. Joseph, for your introduction. So as I was introduced, my name is Doriane Sabushimike, and I'm going to take you through the case presentation, which is the first part of our presentation. And then Professor Mavura is going to continue with the rest of the presentation and we'll come back for the quiz. So our first case is a 27 years old male patient who was sent to us from Simiyu, which is a region which is 6 hours from Moshi. So he was sent because of multiple lesions that he was having at the back of the neck, at the upper part of the back of the neck, which they thought they were malignancies. But on examination, first on the history, there were no history of skin cancer in this young man. And on an examination, he was having erythematous follicular papules. Some were coalescing into crusted plaques with alopecia. On dermoscopy examination, he was having erythema and also some crust with some patch of alopecia, but we didn't see any lesion that could suggest squamous carcinoma, since it was what was suspected, such as the rosette or telangiectasia. They were not seen on the dermoscopy. So our diagnosis was acne keloidalis, or if I can go back a little bit on the dermoscopy. That's why it's not working. No, I'm sorry. So if I go back to the dermoscopy examination, you could see, on the picture it's not very clear, but you could see also some tufted hair, which helped us to diagnose the acne keloidalis nuclei. So as management, he got cryotherapy, which then was done at the clinic, and he got also doxycycline to use for 2 weeks and clobetasol to apply for a month. So the second case is a 36 years old female patient who was seen 1 year ago. She was seen during the clinic of patient with albinism, because sometimes we do special clinic for them. So she was seen last year with this lesion at the right side of the neck, which has been there for 1 month. So on examination, she was having this erythematous plaque lesion, which was on a background of a damaged skin with elastosis, a lot of erythema and freckles. And also on the face, it's not really clear, but you could see also some actinic keratosis on the face. So a biopsy was taken on the lesion, and it's revealed features of squamous cell carcinoma. So a wide excision was planned on her, and it was done after she has gotten prophylaxis of antibiotics, and the margins were clear according to the histology of the sample. So she was discharged with imiquimod to apply 3 times a week and to do a daily dressing at the nearest facility, because she was coming from Dar es Salaam, which is at 10 to 9 hours from Moshi. So the third case, which is the last one, is a 32 years old male patient who was seen also during the clinic of patients with albinism at RDTC. He came from Tanga, the region of Tanga, which is approximately at 6 hours from Moshi. So he came with this lesion, which has been there for 3 months, according to him. He had history of basal cell carcinoma excised on the scalp here at RDTC. So on examination, he was having this nodular lesion with raised crusted edges and ulceration at the center, and it was also discharging some pus, and it was full smelling. So a biopsy was taken, a more surgery was done on this one, and revealed clear margins. So a flap on the other picture that you see, a flap was done, and he was discharged on ciprofloxacin, and also to be dressed at the nearest facility, which is in Tanga. So now I will let you with Dr. Mavura to take you through the following part of the presentation.
Yeah, thank you very much, Doriane. Hello, everybody. As I was introduced before, I'll go take this second part, whereby I will introduce the Regional Dermatology Training Center. Is located in Moshi in Tanzania at the foot of Mountain Kilimanjaro, as you can see the picture on your left side. So the Regional Dermatology Training Center is a joint venture between the government of Tanzania through the Ministry of Health, International Foundation of Dermatology, and Kilimanjaro Christian Medical Center through the Good Samaritan Foundation. The principal objective of RDTC is to improve prevention, treatment, and rehabilitation of skin disease, leprosy, STIs in sub-Saharan Africa through training of appropriate healthcare workers with emphasis in the community in an oriented approach. So the Regional Training Center offers 2 programs, advanced diploma, which takes 2 years, whereby we enroll assistant medical officer and clinical officer. And so far we have trained 301 from sub-Saharan Africa within 17 African countries. We have also a MED program, which offer 4 years training. These are medical officers, and so far we have trained 42 MED, 42 dermatologists from 8 sub-Saharan Africa. So when the RDTC was formed, it has 2 goals. The first goal was to train DDV, advanced diploma, to identify common skin diseases in the rural area and treat them, and refer complicated cases to the district and regional hospitals. So the long-term goal was to form the MED program, which was formed to supervise the advanced diploma and also to treat the complicated skin disease. So at RDTC, we have special programs like the XP program and albinism. Today I'll talk a little bit about albinism. So Albino Outreach Program was formed in 1993 And eventually it became a comprehensive care program for people with albinism, whereby the primary goal is prevention of skin cancer, to give health education and treatment of pre and malignance, with the main aim at looking beyond the skin to attain free skin cancer to people with albinism. So my outline today of my presentation will be introduction. As you can see the outline there, I won't go through it all. So I'll start directly to introduce what is albinism, which I'm aware everybody is aware what is albinism, but it's a group of inherited disorder in which there is lack or reduced pigment, whether in the hair, eyes, or skin. And this will give us the different range of spectrum of albinism, whereby we have localized in the eye when you have only to the eye, and it's called ocular albinism. That has 3 phenotypes, and we have localized to the eyes, to the skin, and to the hair. And this, we call it OCA, oculocutaneous albinism, which has 3 phenotypes. I will not, so I'll go straight to the genetic of albinism. Sorry, what did you? I'll go straight to the genetic of albinism, whereby we won't spend a lot of time here. I know you know quite well. We will talk only to what we are seeing mostly here. We are mostly seeing the oculocutaneous albinism with the subtype of Bokeh, as well as Rukus. So the oculocutaneous albinism, this is the this thyrosinase activity is usually normal. That's why you see when we demonstrate the picture, we see that they have thyrosinase positive, whereby they have colors in a little bit of in their skin and in their hairs. The main mutation is the PGen in the chromosome 18, and as I said, is a yeah. So so this is OCA2, as you can see. He has pigment in the hairs. He has some freckles in the skin. He has brown eyes, and you can see in the other slide on your right side, he has we have albino with his brother, who is quite normal. As we know, it is autosomal recessive, whereby the 2 parent has to have carrying the gene in order to have 25% of them presenting with albinism. The oculocutaneous albinism, as I said, we have also Bokeh type. These are subtype of oculocutaneous too. They have mild mutation in the PGen. They have light brown skin. They have darker colored hair and light brown or gray eyes. So here you can see them in the pictures. These are Bokehs, which we see quite frequent here in our clinic and in our outreach clinics. The other type of albinism we see is OCA3. These are Rukus. They are believed. We have seen quite a number of Rukus here in Tanzania, and they have mutation in the TRP1 gene on a chromosome 9p, and 95% of Rukus, the chromosome, are seen in South Africa, as we have, as I have said before. They have reddish bronze skin color, ginger-colored hair, light color than their skin. The eyes are blue or brown, but their visual are quite normal. I mean, the visuals are very mild affected. Here you can see one of our community dermatologists, Dr. Materu, in one of our outreach clinic, examine a patient with albinism with subtype of rufa. So now I'll jump to the socioeconomic impact of people living with albinism. Well, we as a medical part, we mainly focus on medical issues and not dealing mainly with killing, but we are one of the members of the WHO, and we share the guidelines of making sure that this people with albinism are safe. And Tanzania have taken a lot of initiative to make sure that the killing is reduced dramatically, and the numbers of murder and mutation of people with albinism body, which has been taking place quite a lot in Tanzania, as I believe that by doing so, you might get something like lucky or promoted or get any higher post in whatever you're looking for. We see now in Tanzania that it is quite decreased, and this is because of probably the impact of albino outreach program, which we have been running for over 28 years now. We have managed to integrate them to the society, and they're no longer living in clusters. So the discrimination is a little bit low now, not like before, and we're taking them as a normal person with normal IQ, and given chance, they can really perform as a normal individual. What are the main complications of people with albinism? They usually face quite a number of eye problems, whereby they get a lot of photophobia. They cannot really open the eyes and look because of the light, which is disturbing them, because they have less pigment in the eye, as if you can remember our definition, that they have reduced or lack of melanin in the retina, so they cannot accommodate the light to the retina and see properly. That's why they have also decreased visual acuity, and they have extremely sensitivity to produce melanin as well. Well, they also suffer from skin cancer in their skin. The most frequent skin cancer seen is squamous cell carcinoma, which is the most common, followed by BCC, and very few patients get melanoma or amelanotic melanoma. We have so far only one case, if I remember correctly, with a melanotic melanoma here in Regional Dermatology Training Center. The other damage they face is actinic keratosis, actinic cheilitis, solar elastosis, and keratoacanthoma. These are frequently seen complication of PWA. So jump in the treatment of the complication. As you all know, I'm sure, about, you've seen the AK, what it is, and the management of AK is, we usually do a curettage, or we do freezing with liquid nitrogen, or we use Mickey mode or FDEX if available. But recently we have also been using photodynamic therapy to treat actinic AK, thanks to the Ramon y Cajal Hospital, led by Professor Jean, who managed to give us the apparatus for treating AK by using photodynamic therapy. Also, as we see during development of our presentation, that nicotinamide can also be used to prevent complication or cancers from people with albinism. What I've said already, that we can use cryotherapy, topical chemotherapy, which I Imiquimod 5FU if available. We can use surgeries as our main weapon here, and radiotherapy, which we mainly refer patients with squamous cell carcinoma to the Ocean Road in Dar es Salaam for radiotherapy once it is proved to be squamous cell carcinoma. The eye problem, they have visual rehabilitation. We usually give them visual rehabilitation by working together with eye department. In school, we give them visual aids such as glasses, bifocal, special glasses that they get, prescription reading glasses, magnifying lenses to the primary school kids, whereby they can magnify their notes and read properly. And we have also advised the Minister of Education that PWA, they must get special books with relatively big letters so that they can be able to read properly. So this is what I've been explained to you, that most of the patients are operated here. This is one of our main theater whereby we do operate the skin cancer. And the good thing is now that the MED can all operate themselves. The advanced diploma are now operating themselves. So this is a good, really, achievement. We use photodynamic therapy, as you can see there, and cryotherapy as well in treating of pre-malignant skin cancer. We continue with prevention of complication. Precaution in avoiding exposure of UV light. This is one of the important aspects during our outreach clinic, whereby the people with albinism, they're really educated about the effect of sun damage, that if they can work relatively early in the morning, before 6 up to 10, then go back, or they can try to get any job which is within the shed so that they can be more protected. We also offer them with clothing, long sleeve shirt, long sleeve trouser, hats, sunglasses, as well as sunscreen, which is produced here at the RDTC. They usually receive regular screening for skin cancer as program. We have scheduled an annual outreach program for all our 56 satellite clinics whereby we see them. And we are now looking in future to start having genetic counseling, because most of the people here in Tanzania are carrier of the gene, and it's difficult to know whether you're a carrier or not. This is our sunscreen production unit, whereby you see also people with albinism are working at the production unit. This is our outreach vehicle, whereby we travel to the to the outreach centers, our satellite clinics, whereby we carry liquid nitrogen, as you can see there. We have boxes of small punch biopsies tray, whereby if we see a patient with any malignant there, we usually take biopsy, and we usually communicate with the peer educator at the satellite lesion upon the release of the result, and so that he can bring the patient at the clinic. The other pictures, you can see that before the clinic starts, as I said, they have to get health education about the effect of sun damage and how to protect themselves, and as well as how to apply sunscreen. Usually we teach them every clinic, we remind them, because we have always new patients enrolled in the clinic. Here is, as you can see, myself in the clinic, whereby we're with Dr. Mebrato seeing patient with albinism. Some are waiting to be seen. This was at the RDTC clinic, and some have already received the head, they've received sunscreen. I'll talk a little bit about research. Some research have been done here at the RDTC. One of the research was this, as you can see here. But the conclusion on this was they formed a higher number of colony, which resulted a lot of inflammation, skin cancers. The other research was skin cancer among albino at the University Teaching Hospital in Northern Tanzania. This was in Mwanza, whereby they found that they found about 80% of the cases had squamous cell carcinoma. The other research which was done here at RDTC was histological review of skin cancer in Africa, albino, in 10 years, which was a retrospective review, which was done here at RDTC, and the conclusion was 54%. We're also concluding that squamous cell carcinoma was the most commonest seen, which was similar to the result which was found in Bugando, in Mwanza. We are also looking forward to do a couple of research here at RDTC. Some of these are in the pipeline, like the first one, the use of nicotinamide for prevention of non-melanoma skin cancer in people with albinism. We are working with one group from the US, Professor Harry, yes, whereby the ethical we have submitted the ethical clearance to KSMC. It has been approved, but very unfortunately that we could not receive the nicotinamide with the placebo due to the COVID-19, and that is holding up now. We are also going to impact on use of PDT for treatment of AK. We have started already here at RDTC, and some few patients we have done the people with albinism as well as XP to try to eliminate the AK, the early manifest pre-malignant lesion. Another research was association between multiple freckles and low risk of developing skin cancer. During our outreach clinic for the past 20 years, we've seen a pattern whereby a number of PWA with a lot of freckles, they really don't develop skin cancer as early as possible, or some of them they don't develop. And we believe it's because they have a little bit of melanin, their thyrosinase positive, but we really want to go into detail and see what exactly is some who are developing, we thought, a lot of freckles in this. Another study we are looking forward to do it with Standing Voice is epidemiological study about Rukus type of albinism in Tanzania. Because clinically we have seen quite a number of Rukus here, and if you go through the literature, you can only see that 95% are seen in South Africa and not in Tanzania. But we have seen them, and we would like to scientifically publish that they are here. This is the mark of our end of presentation with Dr. Doriane, and we thank you very much for listening. Dr. Doriane, you want to say something?
Now, and I think it's time to take you through the quiz. Is it that, Dr. Joseph?
Yeah, we have time. We have time.
We have time. So now I think the poll. Okay.
Doriane, we can't hear you.
Okay.
Okay.
Oh, so people have started to answer. So the first question is, what is not true about Rukus type of albinism? So the mutation is in the gene encoding stabilization of tyrosinase and regulation of eumelanin production. The second choice is the mutation is in the gene encoding stabilization of tyrosinase and regulation of melanocyte differentiation. The other choice is some cases have been seen in Tanzania. And the last choice is it is not associated with high incidence of skin cancers. So I'm asking, what is not true? What is not true? So I think, how many have voted so far? 36% only. Giving more seconds. Okay, nobody's voting anymore. So we end up, okay, so yeah, so now most of the people, they say that what is not true is that the mutation in the gene stabilization, there's a mutation that's gene stabilizing the tyrosinase and regulation of melanocyte differentiation. And it's true, because it is, what is true is that it's in the regulation of eumelanin production. So most of you are right, were right. So now we go to take question number 2. Now, question number 2, I'm asking, what is false about skin cancers in patients living with albinism? The first choice is basal cell carcinoma are less common compared to squamous cell carcinoma. Melanoma, a cancer arising from pigment-producing cells, can occur in patients living with albinism. Multiple freckles are a sign of high predisposition to skin cancers. And the last choice is skin cancers are the common cause of death in patients with albinism. So I'm asking, what is false about among those choices? I think I can end the poll. I can. Yeah. So most of you answered that what is false is that multiple freckles are a sign of high predisposition to skin cancer. And you are right, because as Dr. Mavura said at the end of the presentation, we are doing a research to show that it is actually associated with less cancer. Question number 3, it's asking what is not true about the killings of people living with albinism in Tanzania. So the first choice, the first choice is people living with albinism who are used to bring luck to business by placing them into the foundation of new buildings. The numbers of murders and mutation of the patient living with albinism bodies have been reduced. The killing of patients with albinism are performed by family or tribe. The killing of people living with albinism is done in a ritual process. I'm asking what is not true about among all these choices. This is a tricky question. These are tricky choices. I think we can end. Okay, most of you said that the patients with albinism are used to bring luck. I'm asking what is not true. This is true. Mavura said it. So what is not true is that the killing of patients with albinism is done in a ritual process. It's not done in a ritual process. They don't call people and do this ritual when they're killing them. They just, when they see one person, they used to just kill him and take the bones. So question number 4. Question number 4. Now I'm asking what is not true about management and prevention of complications associated with albinism. The first choice is nicotinamide is used to treat actinic keratosis. Surgical removal is not only the management of choice for skin cancers in patients with albinism. Management of other skin conditions are related, that are not related to albinism, is also provided during the RDTC outreaches. And the last choice is biopsy is not mandatory prior tumor excision. So I'm asking what is not true. Giving time to you to answer this one. I think we can end this one. Okay, so most of you say that what is not true is that the biopsy is not mandatory prior to tumor excision, and
that's true.
It's true because we need to do biopsy to know if it is squamous cell carcinoma, because as Dr. Mavura said, sometimes we need to send them for radiotherapy after excision of the lesion, and in squamous cell carcinoma also we should be able to rule out metastasis.
Or the type of
yeah, you want to say something about
no, I mean, what you said is true. Like, also we want to know the type of that skin cancer. If it's infiltrative BCC, then the approach is different. All infiltrative BCC, more surgery should be done. If you do a standard excision, then the chance of recurrence is very high. Then they usually recur. But when it is infiltrative type, you have to do more surgery.
Now the last question, which is question number 5, which is the easiest question. So this one goes on, a person living with albinism has 25% chances of having a child with albinism. The second choice is 50% chances of having a child with albinism. The third one is 75% chances of having a child with albinism. And the last choice is 12.5 chances of having a child with albinism. This is the most easiest question. I think we can end this one. So the majority said 25 chances of having a child with albinism. I think it was also said by Dr. Mavura at the end of the presentation, because it's autosomal recessive, so they have 25% chances of having a child with albinism. This was the last question. Dr. Giuseppe, I think you can take over on the questions.
Giuseppe, I think you're muted.
I'm sorry, I was talking to myself. I was just saying that thank you very much, Professor Mavura and Doriane, for your great presentation and informative of what you are doing there in Tanzania. And now Bayem and Rafente will continue with the questions from the audience.
Thank you, Joseph. Good afternoon, everyone. Thank you, Dr. Mavura and Dr. Sabushimike, for your informative and excellent presentation, the quiz, and your upcoming research topics. The first question is, if margins were clear for the squamous cell carcinoma case, why was imiquimod post-op advised?
Okay.
Yeah. You said why, if the margin were clear, the imiquimod was
Advised.
Well, we to be we had a report from the Dr. Luli, who is our dermatopathologist, about that, and it was we looked the slide together, and we were really not really confident that of course she said that it was really clear, and we had doubt, and we conclude we said it doesn't matter that because we have a session on Thursday whereby we review the slide, and we could see some noodles, and we thought that it's not very clear. It is, but she said the margin are clear according to her, that it was doubling. I mean, that was a challenge with us who are not dermatopathologists, but she tried to explain. But we just gave it for precaution and not because the margin were really affected.
Okay, all right. The next question was, what's your experience with nicotinamide?
Well, with nicotinamide, we are about to explore that, and we are going to do the research. According to the literature, nicotinamide is one of a drug used to prevent pre-malignant lesion, and by preventing pre-malignant lesion, we think we can be able also to reduce the skin cancer in Tanzania. So we have designed a study, as we said. We have not done it, but we hope that we will get the placebo and the nicotinamide soon from US, and we will start the study, and from there we will be able to comment further on whether the nicotinamide can really prevent pre-malignant and hence the skin cancer. But so far the literature say yes.
Okay. All right. The next one, in which cases do you apply photodynamic therapy?
You want to answer, Doriane?
From our experience here, we are using photodynamic therapy for patients with actinic keratosis. in a patient with albinism having actinic keratosis. We have used it also on patients with xeroderma pigmentosum. So since the reagent we get few, because the ALA when we get it, it's little. We don't use for other patients. We use for those with albinism and xeroderma pigmentosum. And there's one study which was published actually last year from Dr. Chapa, who's a dermatologist who was trained here, with Dr. Mavura and one doctor from Spain, I don't remember her name, and they show that it can be used to treat actinic keratosis, and yeah, that's how we are using it for now.
Yeah, in fact, it's a very simple one. It's less cost. It is. I mean, for people who are very aged, I mean, you can just do it easily. They don't have to go through all the admission, all the payment for screening before going to the theater. So it is the easiest way if we can really do it.
Okay, all right, thanks. The next question, what's the frequency of application of imiquimod to the lesion?
Yeah, we usually apply for 6 weeks, 3 times a week for 6 weeks, once a day in the evening.
Okay. All right. The next one, at what age did you begin to see actinic keratosis and squamous cell carcinoma appearing in these patients of your studies?
The age, ranging from 18 to 25. Yeah, 18 to 25, according to that study. And another thing that we should mention about that study is that there are studies which were done previously, like 30 years ago, and they were showing that these patients who were developing squamous cell carcinoma were also dying. Most of them were dying before the age of 30 years. And now with this program of albinism, we have like most of them develop these lesions quite later compared to before, and they reach more than 40 years, 50 years. So yeah.
Okay. The last question. What are the biggest challenges for patient education and prevention, specifically for children and adolescents with albinism?
Mm-hmm. That's a tricky one. Well, the challenge that we face is mostly we found out that, as I mentioned in my presentation, that eventually the albino outreach program has become a comprehensive care program. We have noted that once they're educated, it's very easy for them to protect themselves, especially knowing easily why they get skin damage because of the sun. They can be employed at the different area because they have normal IQ. They are quite intelligent, some of them, and they can work indoor. So this is a major challenge. And education, they lack education. And by lacking education, now they are subjected to work so that they can earn some living. And they tend to work at the casual work which subject them to the sun. And they develop skin lesions. And to them, it's not a major thing, since they can work with it and get the earning and their food. So eventually, by the time they report to us, mostly they have advanced tumor, or they have tumor which is inoperable, and yeah, this is quite a challenge, as well as I did mention in education. We put a lot of emphasis in education of what is albinism and how it should be prevented. And we are now teaching the primary school teachers to take care of these young PWA who are going to school, because if they're given chance, get magnifying lens, they sit in front, they can perform very well. But if the teachers, they are not aware about albinism and how to take care of them, then they are left behind. And so these are the challenges. There are many major challenges. I mean, we're happy that the killing has gone down, which was really worrying. And so far, we have just finished the election soon, and there's no any report of killing of PWA.
Okay. I thought that was the last one, but we've got the very last, quite interesting question. In your experience, which melanoma subtype is more common in albinism patient, amelanotic or acral?
Amelanotic. Amelanotic melanoma.
There's one acral.
Yeah, is a melanotic. Yeah.
Okay. All right. Thank you so much, Dr. Mavura and Dr. Sabushimike. I will hand over to you, Joseph.
Well, thank you both, Professor Mavura and Dr. Sabushimike, for your excellent session and answering the questions from the audience. I'd also like to thank all the Global Training Committee members and ILDS members for their support and help. And thank you all the attendees for your participation, of course. And finally, I would like to take a picture, a screenshot of all the participants. So feel free to join with your camera on. Okay.